Welcome to the Health Informatics Seminar Series. This is the first one for this academic year. I'm Dave Potenziani. I will be acting as your host, but a little bit of ground rules. Please, if you are joining us virtually, mute your microphone so that we don't necessarily get any background noise or your child in the background. However, at the end of the presentation, we're going to have several minutes for questions and answers. And think of questions as you move along. And if you want to, you can pop them in the chat. I'm happy to read them out loud later. But when we come to the Q&A, you may also just unmute yourself and ask your question, and hopefully we'll be able to hear it. We hope. All right. So let's begin. We are going to hear about an effort to link electronic health records to individual level census data from UNC's Professor Barbara Entwistle. She is a distinguished professor of sociology and fellow at the Carolina Population Center. So I will turn it over to her, and please begin.
Great. Thank you very much. Thank you for joining us this afternoon. It's a real pleasure to be here and also to talk about this particular study. Dave was asking me ahead of time, how long did this take to do? And I responded then, and I'll say now, this got started in 2018. And I'll tell you what happened. I got invited up to the Census Bureau to give a talk. And when I was up there giving this talk, and it was about the fact that various kinds of data that we use are not representative, and talking about what the consequences were. And so I used electronic health records as an example, and I used some other examples as well. At that talk at the Census Bureau, which for a demographer like myself is the mothership, was an economist named Victoria Utilova. And she had been wondering about the same thing. So we started talking at that time, and I came home very excited about the possibility of trying to do this and actually look at this at the individual level. Back in the day when I first knew Dave, actually, I was the vice chancellor for research here, which was a good thing. It meant that I knew the landscape and I knew who I needed to talk to. And so when I came back, very excited to do this, I started talking to people over in the medical school and at UNC Health about this, because a random sociologist calling up probably wouldn't have gotten too far. In any case, long story short, finally, this spring, we published this work. And there are other reasons why it took so long, some of which I'll share. In any case, I want to be clear, this is a collaborative effort of UNC Health, and the Census Bureau. And so none of us alone could have done this work. Together, we could do it, but it wasn't easy. And I'll indicate some of the others as well. So basically what I want to do today, and I'm not assuming that you know a lot about any of this, is I want to sort of frame this as the use of health records for monitoring. There are other ways to frame this talk, but this is the one I chose, and sort of explain to you the value of these records for that purpose. Then I want to talk about representativeness. What do I mean by that? I mean it in the way that a statistician would mean it. I mean it in the way that a demographer would mean it. That is, to what extent are you accurately representing a real population? So we often take samples, we make generalizations to a population. The design of those samples determines whether or not we can make claims about the overall population. So that's what I'm talking about. I will say a bit more than I usually would about how to link the data from the electronic health records with data from the American Community Survey, because I assume that you're kind of interested in that. If I'm wrong, I'm sorry. I want to explain why the American Community Survey is a good benchmark for evaluating these electronic health records. And the findings are mostly good news, and I'll review those. then talk about some challenges, why we don't fully really know, and talk about some other implications. But I think there'll be plenty of time for Q&A, and I welcome that. So the talk draws on this article that was recently published. I've introduced you to Victoria Utilova. She's at the Census Bureau. The first person I talked to when I came back was Tim Carey, who at that time was the co-director of the CTSA, the Tracks Institute, and Emily Pfaff, who you must know, or at least have heard of, was key to getting things done, and she has lots of good ideas. Aubrey joined the Census Bureau later. Anisha Ganguly joined the School of Medicine later, and J.P. Powers is a data scientist who joined the Tracks Institute later. So, but that's the team, and this was where it was published. But I'm also going to draw on some earlier publications. So it wasn't that we started in 2018 and nothing happened until 2026. There were some, things along the way that we did, and these other publications are also relevant. Okay, let me say a little bit about representativeness. And this is from my perspective. Dave might give it from a different perspective. It's interesting. So a lot of monitoring that we do relies on social surveys of various kinds. You can think of the National Health Interview Study, NHIS. You can think of NHANES, the National Health Examination and Nutrition Study. You can think of these different studies that have been tracking health. And then there's some other smaller ones. For example, the health and retirement surveys. And those are panel studies, but they are of older populations. In any case, one of the challenges of that way of going about it is that response rates have been going down. And that's what this is showing you. The one on the left is a trend of response rates and surveys up to 2016. The black one is the NHIS, I believe. The orange one is NHANES. Can you see? It's a little hard to see the orange. The orange one's right at the bottom. So, it's better than it looks because the side there, it's, it goes up to 100. So they're only down around 60. But just to show you, things didn't end then. This is another set of surveys, but you can see that the trend continues to go down. So what does that mean? It means that we're not sure. Is that following me? Good.
It's trying to.
I walk around a lot. It means that we're following a group of people of unknown representativeness, and we're doing it for more and more and more money. It gets more and more expensive to do these because we're trying harder and harder to get these people. We have to find them. We have to convince them. As a result, it's become rather expensive. So we've been looking at other ways of doing it. And electronic health records is such an alternative. And increasingly, these records, and I'm going to say records, but I don't really mean that. Nobody's taking records out of the vault. It's data derived from the records, but I get a little sloppy sometimes. So I say records. And just know that I mean the data from the records. But these have been proposed as an alternative. Increasingly, they've been used for those purposes. I could give you a whole bunch of examples, but I won't. I just want to say there's some specific advantages that the EHRs have for this purpose. One is the numbers are large compared to a sample survey where you get really excited if you have a sample survey that's as large as 100,000. Most of them are 20,000 and less. A group of health records, you'll see the ones I'm using, it's over 2 million records. So there are lots of them. That's great. And one of the advantages of that is you can begin to look at very small categories that you could not look at in the surveys. There just aren't enough people in them. But with a larger sample size, you can do some of that work. It's exciting. There's a lot of clinical detail in the electronic health records. You're not depending on recall, which is what you're doing in the surveys mostly. from the standpoint of the user, there's less cost and burden associated with using these. And of course, they're very timely. They're right up to yesterday. I want to quickly say that that these are not the end all be all, and that there are other kinds of problems with them, which I assume maybe that you're hearing about in other talks. But it's true that there's a lot of clinical detail, but it's also true that there's a lot of missing data that is uninterpretable. It's true that for you, the data collection cost and respondent burden is less, but that's not true for the patients and for the medical system. So I just want to be clear that this is all from a particular perspective. But using these data is a little bit risky without some further evaluation. What you have here is a population of people who seek and obtain healthcare. And that may or may not be representative of any population you would want to know. When you're doing monitoring, you're not just looking at who's getting care, you want to look at everybody, right? So there are concerns about whether patients captured in these records are representing everyone in a given place. Could be neighborhood, city, county, state, nation, whatever. And uncertainty about this could limit their use. And why? There's a risk of biased estimates because your denominators and numerators are kind of messed up, especially your denominators. You figure out your health situations are mostly being covered because people with them come to get care, but it's the denominators that are often lacking. You can be misled in terms of what the trends are. And of course, generalizability is a question. So there's a key gap, and that is that the nature and extent of the problem is still unknown. And that's what Victoria and I talked about in 2018 and what we have now done. Okay. We wanted to do these linkages at the individual level. And we wanted to compare the health system's data with a population representative benchmark, right? So how do you know if you're representative or not? Well, you need a benchmark. You're going to compare it to something. So what we did, and what I'll talk to you about, is linking individual patients to respondents, and that's not quite accurate, in the American Community Survey. I'm going to say respondents, but really this is a household survey. One person responds and reports on everybody, so just bear with me on that. Okay, we have 1 year ACS microdata, and the general idea is if I start with a representative survey and I try and predict who I find in the records, if there's no bias, none of those predictors will have any effect. That's the idea. That's the basic idea. We'll come around on that. Okay, so what are we doing here? There's sort of a demographic piece and a socioeconomic piece. Demographic piece, others have looked at this. You can compare UNC Health records with the state of North Carolina and find out right away that it's an older population. It's a more female population. This is not new, and so we know some of this already. But we wanted to look at selection at the individual level, not only for age and sex, but also for race and ethnicity, for household size and household language. So those are demographic characteristics that are not typically looked at. I've done a lot of work on race and ethnicity. So if you want to talk about that later, I'm absolutely fine. But just to give you a heads up, if you do it only based on the records in the health system, there's a lot of missing data on race and ethnicity. And I've done a lot of work to figure out who's missing. But anyway, if we start with ACS, that's not a problem. Okay, so a lot is already known about demographic selection, but this is more precise. Nothing is known about socioeconomic selection. That's too strong. Not a lot. So the idea is that there are characteristics of people like educational attainment, employment status, poverty, health insurance coverage, these things which also is going to influence whether or not people are in the records. But there's no, except for insurance coverage, there's really no information about that in the records themselves. So no way to sort of create a statistic based on the record that you could compare to a statistic based on some other data set. So you probably know this. Well, I'll give you one little story. I was asked at one point by folks over in the medical, in the healthcare system, if I could add one thing to the healthcare records, if I could add one thing, what would it be? And, you know, as a social scientist and knowing the power of educational attainment, I said, educational attainment. And she said, oh, we can't use that. It's not actionable. Meaning, if somebody has a, you know, whatever their educational attainment is, there isn't anything the health system can do to change it. And so they want to know things that they can influence and intervene on. So just to say it's not there, and there's a reason that it's not. So we don't know a lot about the selection on these variables, and that's part of what was exciting about this. Okay, so to do it, I've sort of explained to you where we were at. I've explained to you the basic logic of what we're going to do. But I thought you would be interested in some of the story about how data get linked, because this is informatics and this is what you all do. This is showing a graphic that really is outlining the collaboration between UNC and UNC Health and the Census Bureau. And within the Census Bureau, we're working with something called the Enhancing Health Data Program. And Victoria's in charge of that program. So, you know, what is UNC Health? We are this public integrated healthcare system. It's huge and it spans the state. I think a lot of people don't necessarily know that. When you say UNC Health, they think you're talking about Chapel Hill, and you're not. It spans the state. As part of this, we discovered that there's at least one patient in every census tract in the state. So it really is. It's large. And according to the UNC Health's own estimates, they cover 20% of the state population. I'll come back to that number. Okay, so what we drew was a sample. Well, we drew everybody, 2.12 million patients. And I'll say more about that selection. eHealth. So what's in it for them? So what's in it for us? This is all about what's in it for whom and what and all of that, because that's what you have to do to pull off a collaboration. For UNC Health, they were going to learn a lot about communities that they're serving and not serving and how these records can be used. What's in it for eHealth? They are in the business of repurposing data, and they're in the business of trying to modernize federal statistics. So there are little lessons learned along the way that have been useful for them. Okay, so they supply the ACS, or American Community Survey data. We're providing the data from the health records. Okay, a little bit of a story here about what it's like to work with such different organizations. We've got different missions, different cultures, different governance practices. It's exciting. So, you know, the mission of UNC Health is to serve the healthcare needs of people of the state. That's not the mission of the Census Bureau, right? They're trying to provide statistical descriptions of the American population. At UNC, there are lots of different groups that got involved in oversight. The Clinical Data Warehouse Oversight Committee, that was critical, and really appreciate their help. Emily Pfaff served on that, was critical sort of liaison. She's also on the study. We went through the IRB. We needed to do that and explain what we were doing and so forth. All of this is HIPAA protected data. So we're using these data for research purposes only, and we're only using what we need. OIC stands for the Office of Industry Contracting. They're the ones that actually do the negotiations. And OUC, Office of University Counsel, are the lawyers who get involved in all of this. That's a lot of people here. The Census Bureau, it's a completely different cast of characters. They are not bound to the common rule as we are. Instead, it's Title 13, which is a federal regulation that is about the use of data only for statistical purposes, highly protected. data. Okay. So at the Census Bureau, everything goes through a disclosure review committee and a whole bunch of other committees, most of which I appreciated. Like when you're getting ready to publish a paper, it goes through a committee that literally checks every single reference in your paper, not just to see if it exists and you have it cited right. No, they go back to the paper and they find out whether or not what you're saying about that is actually exactly true. And it's great to have that backup, really, although it can be annoying. In the end, the data use agreement between us is called a joint statistical agreement. And I underline statistical for a reason. So this took a month, just to give you a sense. This is language of the Census Bureau. This is what they call it. They sent it over here. Lawyers here and others here said, we can't call it that. We're going to call it a joint research agreement. Send it back. No, we can't have that. We don't do research at the Census Bureau. Send it back. How about joint statistical research agreement? Nope, can't have that. Lawyers won't have that. Okay, we give up. So it took, but it's difficult because the language here isn't really HIPAA-like language, right? This is a research project. Anyway, but that's part of what I'm trying to tell you. It's really hard to pull these things off because just even the language is so different. I have a whole hour of stories like that. Okay, so we are selecting structured data from the EHRs. How are we doing it? There's some inclusions. We want patients with 2 or more visits, at least 30 days apart in the 5-year period of interest to us, which was 2018 to 2022. Why 2+ visits? It's because we don't want just the random person who broke their leg skiing and showed up in a hospital and then went home to wherever. We're looking for patients that have some continuity of care. And so that's why. They have to have a North Carolina address at some point, but not always. So people coming in, people leaving, that's all okay. We have some exclusions. You may know that UNC Health treats people who are in prison. None of those people are in our data, at least not when they were in prison, and I don't know about them. And patients who are missing date of birth. They're not many, but we did exclude them. So we ended up with 2.12 million patients. Okay, so what do? We had that, and we also had a lot of identifying data. You'll see why. And some other, the specific health data that we needed. And this was transferred up to the Census Bureau IT systems using secure manner. Once it's there, it's an absorbing state. It never leaves. It never leaves. And this is something that's sort of hard to appreciate because lots of people, when they hear about the linked data set, oh, great, now we can come back and we'll know, all of these characteristics of the patients. No, the data stay there. They can't come back. Okay. So, and the people having access to it are people with special sworn status. And that is folks working for the Census Bureau, and then other folks who, in essence, become temporary employees of the Census Bureau in order to work on it. So people here at UNC have special sworn status, and it's a big deal if you violate this. You're fired, okay, but you're also fined. We're talking 6-figure fines and 5 years in prison. Now, initially, people here were thinking, geez, they're not really sure about the security up there. But you can think about violations of HIPAA and whether they would end up in any of those particular outcomes. So they're very serious about this. Every statistic, every table, every number goes through a stringent disclosure review. And they're evaluated with respect to a privacy budget. Have you all talked, this is the beginning of semester, so you wouldn't have any sense of that. Are you going to talk about it?
This is open to the speakers bringing whatever topic they want to talk about.
Okay, privacy budget. Okay, so the issue is, can you identify people based on the information that's out there? And you know, for example, if you've got somebody's social security number, you know who they are. But you also know that combinations of characteristics get pretty close. Like an example I give in my undergraduate class, if I'm looking for a sort of Hispanic boy born on a particular day in North Carolina, there are 31 of them. And I don't need to know much else to figure out who they are. Okay. So this is the worry. And Title 13 is all about you can't disclose identities. And so they worry about this a lot. There was an economist, John Aboud, who's up at Cornell. He was the chief scientific officer at the Census Bureau in the latter 2010s. And he and others up there took the data from 2010 and all of the tables that were out there and tried to re-identify who was in the census. They succeeded about half the time. Now, this is a big controversy, and you can invite me back for another hour on that. But that's where the notion of a privacy budget comes from. Every little thing that gets published is leaking, in essence, information. And so they're very, very careful about what they release. For those of you who are into statistics, they're fine with things like regression coefficients. You can have as many of those as you want. They are not fine with all the tables you might imagine doing. And in the health world, contingency tables, that's how people work. Okay, results are often rounded, especially in crosstabs. And one of the things that's hard about the way we work here is you can't talk about the results to anybody outside of this, anybody who doesn't have special sworn status, which means that if you're collaborating with somebody who doesn't have it, you can't tell them what you're seeing in preliminary analysis. They just have to trust you. Okay. Okay. So what do? They get up there, and how do we do the linking? They have what are called protected identification keys. These are anonymized personal identifiers. And there's a reference file of them compiled for all kinds of federal data. And so what's done is you're comparing the identifying information from the health records to the identifying information in the reference file and trying to see if you can match. And if you can, bingo, you assign the pick. And if you can't, you don't. Okay. So early on, people were wondering, could we even pick the UNC Health patients? And yes, we can. That was one of the first things we showed. But in this study, over 98% of the patients were receiving picks. The rates vary systematically. They're lower for Hispanic individuals. They're lower for individuals who are uninsured. I'll come back to that. Okay, we use the American Community Survey as a benchmark. Like, what do we want to compare to? Well, the mission of UNC Health is to serve the state. So the state represents the catchment area for UNC Health. So our population benchmark is all of the North Carolina residents who responded to the ACS in this 5-year period. What is the ACS? It is a national annual cross-sectional sample survey that collects detailed social, economic, housing, and demographic information about people residing at a probability sample of addresses. Okay, it has a lot of socio-demographic information that's missing from the health records. So I could have framed this whole thing in terms of what we get from social determinants of health and the analysis of those, but I didn't. I did the monitoring one. It's designed to be population representative. Response rates are generally quite high. It's actually participation is mandatory, just like in the census, for whatever that's worth. But you saw the other response rates, and it's considered a gold standard. It's used for lots of purposes. So when you go into the ACS and you look at this 5-year period, how many people were included? How many of them were assigned picks? It's a little over 500,000. Okay. Now, people respond to the ACS, they too have to be compared to the reference file and given a pick. It's the pick that enables us to do the linking, right? Once you have a pick, you can link to anything up at the Census Bureau. You have to have permission, lots of permissions. But what we found was that 18% of the respondents in the ACS linked to the patients in the EHRs. That's not bad. The estimate of the health system was 20%. I don't know how precise that was. It's pretty close, 18 to 20%. So we were pleased. I want to be clear about this. Comes from an earlier publication, but it helps make some points about this. We've got the state population, we have EHRs, we have the EHRs with picks. We have, so we have a subset. And on the other side, we have the state population and a sample. That's what those green boxes indicate. It's a sample, it's not everybody. So we're looking at sort of where we're matching and where we're not, but we're not expecting to match everybody. So in earlier studies, when our match rates were, 15, 16, 17%, people were like, oh, that's terrible. Well, no, we weren't really expecting to match everybody. So what we're doing here is we're starting on the right side with all of those people who got selected and picked, and trying to predict who we find on the left side. Okay, so to do that, we estimated weighted linear probability models. These are just like regressions on the effects of person-level demographic and socioeconomic characteristics on the probability of appearing in the records. Okay, so if the patients were fully representative, the predictive effects would be small. This is what I started with at the very beginning of the talk to explain the logic here. So we've got a representative survey, right? And the chances that that one matches to the records would be, that would be 1. It wouldn't depend on the characteristic of that person. So when I'm looking at these characteristics of persons and predicting if there is an effect there, that tells me I've got some selection on that. Okay, so that's the setup. And the results I will show you are adjusting for everything in the analysis. Okay, let me walk you through this. So this is results for demographic variables, okay? Only demographics. We'll get to the socioeconomic variables in the next slide. On the far left, okay, and the variables and their categories are across the x-axis. On the far left, that sort of pinkish bar, that's sex. The green bars are date of birth. Since we've got different dates that we're looking at, we use date of birth, not age. Then the green ones are, in this order, Hispanic, Black, Asian, 2 races. And then the 2 blue ones are household size, and the purple one is whether or not the household speaks English only. So what we're looking at here is the percentage point change in the likelihood of identifying somebody in the records if I know that about them. So let's talk about that. So the first one, the pink one, is sex. So what that is, the reference here is male. So what that's saying is if it's a female, I'm 4 percentage points more likely to find that person in the records. Okay, so it means we're overrepresenting females. We're not surprised by that. Why not? Because we know women are more likely to be using healthcare, at least, in most ages and so forth. So that is not a surprising result. Okay, so the next one, those are dates of birth, and we're comparing with people who were born before 1940. So what you can see there, those are under the line, meaning these are underrepresented. So over the line means they're overrepresented, under the line means they're underrepresented. And you can see as you go from 1940 to the present, more and more underrepresentation, meaning we got pretty good coverage, pretty good representation of older people, but we're missing younger people. Are we surprised by that? No. Why aren't we surprised by that? It's because younger people are, less likely to be using healthcare. Okay, so we're not surprised by that. The next one is race and ethnicity. The reference category here is white. You can see these are below the line, meaning these groups are underrepresented. And you can see that Hispanics are underrepresented by about 0.5%, not very big. Asians are underrepresented more, but they're a very small portion of the population of North Carolina. And two or more races, it's just flat. So there's some suggestion of maybe a little bit of underrepresentation of Hispanics. I'm going to come back and argue that the problem is worse than that, but I'll tell you why later. Household size. The larger the household, the more likely we are to find them. You're not surprised by that. I wasn't either. And English-only households are easier to find. But these are, on the whole, fairly, except for sex and age, these are small differences, really, pretty small. Okay, here are the socioeconomic variables. As I said to you before, this is entirely new. We didn't have information about this. Same setup. What we're looking at, the ones above the line are more likely to be represented. The ones below the line are underrepresented. Across there are the different variables. The pink ones are education. The sort of olive one is employment status. The green ones are sort of relative poverty of the household. That bright peacock blue one are food stamps. Then we have public assistance. And then the purple ones, actually they're more like magenta, are health insurance. Okay, so let me talk you through what's here. First of all, the more education you have, the more likely you are to show up in the health records. And it's especially so for people with an undergraduate degree and remarkably for those with a graduate degree, right? They're much more likely to be found. Now, before we get too excited about that, there are not that many people with graduate degrees, but it's a very marked effect. The next one, we're comparing to those who are employed. The unemployed is the one on the left, no difference. Not in the labor force is the one on the right, that olive one, and it's huge. And these are mainly retired people who are not in the labor force. They're easier to find because they are more likely to be utilizing healthcare systems. Poverty status. This one was interesting. Basically, it's at the ends, there's no over or underrepresentation, but in the middle, there's underrepresentation. So UNC Health is underrepresenting households in the middle of the range. Dave's making a face. Yeah, I know. We're overrepresenting people who are on food stamps. That's the peacock one. And we are overrepresenting those on Medicare. We're underrepresenting those who are uninsured. That's the last one on the right. Okay, so clearly there is something to know about these socioeconomic effects. So I'm going to just summarize, and then I want to talk about some of the implications. I think we're good. We have enough.
We're fine.
Yeah, we're fine. Okay. So what we find out is that UNC Health patients overrepresent females and older individuals. We knew that. Otherwise, they modestly overrepresent some groups and underrepresent other groups, with most differences really being small. That's the mostly good news. The demographic characteristics here, we've confirmed and extend other evidence on this. That we're overrepresenting women and older individuals and insured patients. We're underrepresenting Hispanic individuals. Again, more on that momentarily. With the socioeconomic characteristics, this is entirely new evidence. This is what Victoria and I were wondering about all those years ago. We are overrepresenting more educated people, underrepresenting the middle of the socioeconomic distribution, overrepresenting those on food stamps, and overrepresent insured individuals. My take on this. We still have is if you can think of socioeconomic status as a continuum, and we have different ways of measuring it, right? What this suggests to me is that representation is high at the ends and low in the middle. So we are overrepresenting people at the top and overrepresenting people at the bottom and underrepresenting people at the middle. And we can talk later about why you think that might be. But that's the pattern as I see it if I sort of look across these. And for the most part, these are patterns that mirror healthcare utilization. Limitations. There's always the obligatory limitations slide. So one limitation, we're treating the ACS as if it's representative. But we can't include those who did not participate in the ACS. When the ACS produces its estimates, it imputes values for people who didn't respond. It uses a variety of procedures for this, but the statistics that you see out of the ACS are all corrected for this. But we cannot try to match imputed individuals, right? We have to work with the original data. And so we are more vulnerable to these issues of response than the overall estimates. And we know that there are differences in who participates and who doesn't. And in fact, minoritized individuals are less likely to participate than whites. Okay, so I'll come back to that. And we cannot include those who did participate. We can't include those who did not receive PIC assignments. One of the things that we got to do as part of the study is release PIC assignments for the ACS nationally and the North Carolina. Before that, there was just one little study from 2010 that had these things released. So I was very excited about that. And what we do know that Hispanics, for example, are less likely to receive PIC assignments than other groups. So it's sort of like 0.89 as opposed to 0.98. Okay, so they're a little bit. And likewise, we cannot include patients without PIC assignments. So in a way, what we're doing here is we're focusing in on kind of the ideal data set. Everybody's been found. Everybody's links to this federal reference file, right? But the hard cases, the ones without PICs on both sides, are not in it, right? And so we may be overstating the degree to which things are representative, and yet it's the best out there, and I still am very proud of it. But I think for Hispanics in particular, they are underrepresented in terms of response rates, underrepresented in terms of PIC rates at the ACS, and underrepresented in terms of PIC rates here at UNC Health. And there are all kinds of reasons for that we can talk about if you want. But that's why that little bit that we saw, I wouldn't want to generalize. I think that there's a lot more underrepresentation of Hispanics both ways. Okay, other limitations you might have noticed, this is 2018 to 2022. Well, there was 2020 in the middle of that. And the ACS that year was designated as experimental. They had issues in the field. And of course, healthcare utilization was kind of unusual in that year, a lot of telehealth and other kinds of things. So we're aware of that. We don't think actually that that's driving the results, but we acknowledge that that's an issue. And then the question is, is this unique to UNC? Is it unique to North Carolina? And it's hard to know. UNC Health does have this statewide mission. Not every healthcare system does. And so it may be harder to sort of link up what the catchment is with some demographically meaningful area. And the other thing, of course, North Carolina, we're the 9th largest state in the country now. We've had a lot of recent immigration. And so there's a lot of population dynamic that way. We also were late after this. in expanding the ACA. And so that may, the Affordable Care Act, and that may also be relevant to how far this generalizes. I don't know. A few words about implications, though. So what we're doing here is we're assuming that what you have are the EHRs and you don't have the ACS, right? Because if you have them both, well, they're, world's your oyster. But if you've got high quality data in the electronic health records, those would be age and sex and health insurance. There's really good data on that, very little missing data. You can really depend on it. There's moderate selection on these things, and we would suggest that you just weight the data. And that's what most people do. So then there's some like race and ethnicity, which are varied quality in electronic health records. At UNC, it's about 10% missing, and we're very proud of that. In some other health systems, it's up to 50% missing. I mean, bad. And so ours is, that's why we say it's varied. But we're seeing some small selection there with that caveat, and we suggest weighting if feasible. Then there are things that are completely absent in the electronic health records, like your socioeconomic characteristics. We're just seeing small selection on those. Weighting really isn't feasible because you don't have anything to weight on within the records, but the bias is likely to be small. Now, this is the use for healthcare monitoring. At the bottom there, it says if what you want to do is analyze, for example, social determinants of health, then you've got some other issues to deal with, and those are beyond what my talk is about today. So, lots of people to thank, including the NIH for their funding, the Enhancing Health Data. I also want to thank the UNC Health and all of the people in the TRACS Institute and others. Thank you.
So I'm going to turn it over to my students first and put them on the spot if they have questions. Go ahead.
Really awesome talk. Thank you. I'm curious if as you were talking about and showing the effects especially, I was wondering about if the effect was different in areas where UNC had a larger footprint or a smaller footprint. I was thinking of Charlotte, predominantly low income, but mostly served by Atrium Health as opposed to UNC. So was there any look at more granular areas than the entire state? Did you look at the triangle and then compare the effect sizes versus the statewide effects, for instance?
Right. Doing that is not consistent with our data use agreement.
Okay.
But what I can say is that that we've done some work where we were looking at census tract characteristics. And so we did that. And that would be taking into account some of that variability, right? And we found similar patterns when we did that. But yeah, I would love to do that.
Okay.
And you're right. Charlotte, we don't cover well. Winston-Salem, parts down east. It's a mix. The big ones are Atrium, Wake, UNC, and Duke, and all of us have a different piece of it. And so that's part of the challenge. So this is just the UNC piece.
Sure.
Yeah.
Thank you.
Related to that, do you think that the economic status is slightly influenced since UNC has that bigger reach here in Carver and Chapel Hill, and usually like housing prices are higher here, like overall we're more richer compared to other more rural areas in North Carolina. Do you think that could influence this analysis?
Well, I guess we're not taking into account where people are. I think that it can, in the sense that I think UNC Health probably pulls a lot of the people who work at this university, right? And you're going to get a lot of pretty highly educated people that way. But you would expect the same to be true, with Duke Health, right? They'd be pulling a lot from that university. They wouldn't be coming here. So So yes, it's complicated. But I know that studies that have just looked at UNC Hospital find that selection, and it's easy to explain the way that you just did. But we've got the whole state. So I guess I think that's probably part of the reason, and yet it's not fully satisfying.
We have a question online. Let me see if I can reinterpret it. Is this data available for anybody to do research if they go through the proper steps?
Yes, but the proper steps are, there are a lot of proper steps, meaning that it would have to be somebody with special sworn status who submitted a project proposal that had been approved and reviewed by the Census Bureau, that had a place to work probably in one of these. The Census Bureau has some remote statistical data centers. There's one on this campus, there's one at Duke. You have to have access to that. You need to be approved by UNC Health. So my hope from the beginning was that this could be a resource. But it's at the point where it's still hard. And my other hope, here's a dream, is that we could get Wake and Duke to join with us and do this for all of them. Now that's really out there as a dream.
Great. Good.
So I was just curious, when you were talking about collecting data, you mentioned exclusions and you excluded prisoners. Why was that?
An IRB issue. They're a vulnerable population, and nobody using the records can include the prisoners.
They don't get to choose their health care. So they're often not able to be used for research. Because when you use UNC Health, you agree to go to UNC Health. In the prison population, you don't get to choose where you go.
He scans the room. All right.
Yeah.
My turn.
Okay.
So it sounds like your hopes for the future to expand this approach, perhaps with some neighboring institutions. Have you thought about going even more widely to talk to groups out of state to be able to replicate this in other states so that you would add that kind of data to your approach?
Yes, I have been talking to people in New York City at Columbia. I have done that. It's really hard. These data use agreements are really hard. It took 9 months to negotiate this one. And, I can just imagine trying to get one that's going to please all of these different places. It's not a trivial task.
Is it just the data security issues? Because when I was working in this field, we ran into some expectations that had been sort of, shall we say, set by the clinical trials industry, where people expected to be paid for access to their data. Have you ever run into that?
No, we haven't. This is, the HIPAA regulations used for research. You may not realize it, but when you sign your forms as you go in to get your healthcare, you agree that your information can be used for research purposes. So no, and that's not the nature of this. There's no direct benefit. There's no direct harm. So it's a very different kind of thing.
Okay.
Yeah.
I will use up all your time.
Fine, please.
I was on a team that did some research using all of us to answer a somewhat similar question, and we were looking at prevalence of a few disorders and generalizability of the all of us sample to what was reported in his was our gold standard for that particular study, and it varied a lot. Like depression, severely underreported in all of us. Dementia was overreported in all of us, even after trying to account for age. I'm curious if you've thought about all of us as a possible means for answering this question, because those demographic variables are available for essentially everybody, including the socioeconomic factors.
All of us. There's a story here.
Oh,
How much am I going to share? Maybe I'll share the rest of it when we're not being recorded. I am not a fan of all of us. I am on record as not being a fan of all of us. It is a population of volunteers. It is not representative of anything. And it's bothered me from the beginning that has not been fully recognized. And so far, from what I can see, is that people think about it when they are comparing descriptions, like how many people are like this and how many people are like that. But when you start doing analyses where you're interested in the cause of something, these selectivities are going to completely undermine any inference that you might want to draw. And so a lot of money has been spent on this. Unbelievable amounts of money has been spent on it. From my perspective, I don't think it's a good investment. How about that for a strong opinion?
So let me ask a little bit about the possibilities of other institutions following this approach. Have you thought about, as some groups have done, create a cookbook to help an institution who is interested in making these linkages and studying data in this way, what steps they might need to go through so that they aren't just lost like you were, it sounded like at the beginning?
Yeah. So I didn't tell you, this was funded as an Element E project in the CTSA. So the Clinical Translational Science Award in this most recent round was requiring UNC to do full-on research projects, and that was Element E. And this project was one of the first two Element E projects. A little over a year ago, there was a review of NIH funding, and this project was deemed unacceptable because it was looking at social determinants through an equity lens. I believe that's a quote. And so our funding was discontinued. That was one of the things that we were thinking about doing.
Let's see. Okay. So it sounds then that it would be difficult to, you pointed out that there were legal restrictions on the use of data in some ways. But it sounds like the benefits, health benefits, social benefits, could be substantial if such data were made available. How would you advocate to somebody in a Congress or in a legislature to be able to make this an easier process while still protecting privacy and the like?
Yeah, I'm not sure it would be Congress I would be going to. It would be Howard Lutnick. No, seriously, it's having to do with what the rules are about the data. And ultimately, the Census Bureau is in the Department of Commerce. And so that's why I'm thinking of him. And his office would be overseeing this, not only for the Bureau, but for other organizations within that. I don't think I would get very far because we're in a period of transition right now. There was on June 26th a disclosure avoidance order, which promulgated some new rules about how census data would be reported. And so we're still trying to sort our way through that. And we don't fully know yet.
Okay. We have a couple more questions online.
Sure.
One person is asking, did FHIR HL7, the data standard, come into play at all in your research? And if so, how?
It did not.
Okay. So you were at a much more granular level than those kinds of approaches.
Yep.
All right. And you mentioned that the data shows over and under representation. Do you think it has to do with economic changes in the middle class to essentially discourage participation in the health system.
That's an interesting thought. I hadn't thought about that. I guess I was thinking about it more like where do people in the middle of the distribution go? Did they go to UNC Health or did they go to Duke? And I was guessing that some of that was related to that, but I don't know. It's an interesting thought about who's coming for care, and I'd like to give that some more thought. So thanks for that suggestion.
All right. Last call. You don't have to go home.